Welcome back. We'll proceed to our final session of the day. Please allow us to introduce our next esteemed session chair, Dr. Ayman Rahmi, Conference Chair, Chief of Neonatology, Tawam Hospital Al Ain, Assistant Professor of Pediatrics, UAU and Khalifa University, Abu Dhabi. Please give him a round of applause. The session is yours, Doctor.
Thank you very much. So we trying to extend our attention span until the 5 o'clock. I think we're going to get started. People will join us later on. So this session is about pediatric cardiology. We have privilege of having guest speaker from United States, from University of Iowa. Dr. Bassel Mohammed Nijres. He's American Board of Pediatrics, American Board of Pediatric Cardiology, and he did a fellowship in addition to having pediatric cardiology fellowship at Rush University in Chicago. He has also pediatric interventional cardiology at Texas Children's Baylor. And he's going to talk to us about a very controversial, and it's actually a new field in neonatology about catheter closure or non-invasive catheter or PDA closure. So he's going to talk to us in the first lecture and the third lecture about this. So please join me to welcome Dr. Bassel Mohammed.
Thank you for the organizers for inviting me. It's really my pleasure to be here today. So we'll not talk about indication of PDA closure. We'll just talk about how we can make this procedure simple to the point that we can provide this procedure at bedside. I have no conflict of interest. So we'll discuss the history of transcatheter PDA closure, and then we'll move towards how we perform transcatheter PDA closure in older children. Then we discuss difficulties associated with transcatheter PDA closure in premature infants. Then we'll move towards the steps how to achieve bedside PDA closure. The first step, we'll discuss how we do transcatheter PDA closure in the cath lab using contrast. Then the second step, how to do PDA closure in the cath lab without contrast use. And then the last step is how to proceed with bedside transcatheter PDA closure. There are many devices available for PDA closure. The first transcatheter closure was reported in 1979. Mortality rate and complications are very rare. And nowadays, transcatheter PDA closure is considered the first line of treatment in older children. We prefer, though, the patient weight to be more than 6 kilograms. Here are some pictures of the devices that we have. None of them few of them are not FDA approved, but we still use them, and we have great outcome with those devices. As you imagine, each device has advantage and disadvantage. The principle is the same, is to put the plug or a device inside the PDA and closing the flow from the PDA from inside, which is different from the surgery where the surgeon get the PDA from outside. Are the classic steps of PDA closure in older children. In older children, traditional way to close the PDA is to get two accesses, one in the venous, usually femoral vein, and arterial access, femoral artery access. We start with the femoral artery access, we put catheter in the aorta, and we take picture in the aorta. The reason why we start in the aortic picture is basically to delineate the anatomy. We basically look at the shape of the PDA, and we measure the size of the PDA. 3 measurements are important for us: the smallest diameter, aortic diameter, and the last one is basically the length of the PDA. Then after that, we cross the PDA from the venous axis in what we call prograde fashion, meaning we advance the catheter from the femoral vein into the inferior vena cava, the right atrium, and then to right ventricle, main pulmonary artery, and we put the catheter in the PDA. Then we exchange the catheter to the delivery system. As you see in this picture, the delivery system or delivery catheter is large, and this is one of the drawbacks or the difficulties in the past in closing the PDA in premature infants. And this is another reason why we prefer to close the PDA from the femoral venous axis. Placing a large catheter in the arterial axis carries a risk of causing thrombosis, spasm, and also risking losing the leg perfusion. And some patients, unfortunately, though it's very rare, but we can lose the extremity from that, from placing a catheter in the artery, in the femoral artery. After we place the device inside the PDA, we take a picture in the main pulmonary artery, and we take a picture also in the aorta to make sure the device in good position with no residual flow. When we are happy, we release the device, and we take a picture here to make sure the device, again, in good position and did not move after releasing the device. In older children, we don't need echo guidance. We can do all procedure in the cath lab with contrast use. Though there are difficulties in closing PDA in premature infants, I would divide those difficulties into two groups. Non-modifiable factors that we cannot modify those factors. For example, premature infants are small. We always say children are not small adults. Same thing, premature infants are not small children. They are distinct group of patients. They have specific comorbidities like RDH, bronchial dysplasia. They are very vulnerable. They have small anatomy. Everything is small. The heart is small. The vein is small. Everything is thin. So the procedure is not straightforward and carries definitely some risk. Modifiable factors, those factors that we can modify and makes the procedure easier and safer. First, arterial access is difficult and risky, but nowadays we can perform the procedure through a single venous access. We don't need arterial access, but because we don't have arterial, we cannot take aortic angiogram. So instead, we rely on the echo to guide us with the procedure. Transferring the patient, it's really a hassle, and it's not easy. Usually, it's improved with experience. And also, if we consider bedside closure, then we can avoid transferring a patient and the possible instability with transfer. Need for contrast use. Although we use small amount of contrast, but can cause kidney injury, can cause also transient hypothyroidism. How we can tackle this problem? First, we minimize the amount of contrast. We give 1 cc of contrast. We can dilute the contrast, and if we can do the procedure with echo guidance, then we can avoid the giving contrast. Staff familiarity, as you imagine, any new procedure is new to the team. There will always be a few questions. There will always be concerns. I think it's a teamwork. Everybody needs to speak up, discuss the concerns, and try to come up with a clear plan. Debriefing is very important with the process of closing PDA by cath. So after the procedure, I would recommend discussing what went well, what went bad, and learn from the experience, and to make the subsequent procedures easier and more straightforward. Equipment. In the past, we don't have devices like soft devices, small devices, that they can go inside or can deliver through small catheter or like through soft catheters. Nowadays, we have those devices. This picture of the Piccolo device, probably you hear about this Piccolo device, was approved in 2019. It can be delivered through small catheter only for French sheath. We have 2 additional devices. We sometimes use them in the United States. They are not FDA approved, but also they are soft and can be used and delivered through small catheter. Piccolo device comes in 3 different sizes, 3 millimeter, 4 millimeter, 5 millimeter, and each size comes in 3 different lengths, 2 millimeter, 4 millimeter, and 6 millimeters. All those devices, regardless of the size and length, they can be delivered through small 4 French catheter. This basically shows the overall workflow at the University of Iowa. As you see, to close the PDA is a teamwork. A lot of people need to be involved. We need cardiac anesthesiologist, we need the NICU attending, we need the respiratory therapist, nurse, technician, to support before, during, or before the procedure, and support us during transporting the patient and during the procedure as well. The workflow can be divided into 3 subgroups: in the NICU, and during transportation, and in the cath lab. In the NICU, before the procedure, patient should be screened for hemodynamically significant PDA. Unfortunately, we don't have clear definition what hemodynamically significant PDA. It's an area of debate. I think it should be risk assessment for many factors like echo factors, clinical picture, and with the echo, I don't mean only the PDA size, but also any factors, any other factors to quantify the amount of the shunt. The size doesn't matter. What matters actually the amount of the shunt across the PDA. Then the NICU team communicate with us. We assess the chart. We look at the echo, and if we decide to proceed, then the patient gets intubated. If not intubated yet, get stabilized, like get muscle relaxant. We obtain 2 IV lines. We get inotropics in the line. After the procedure, we assess respiratory status and de-escalate the respiratory support as appropriate, and we assess the patient hemodynamically. So if we need to give inotropics, if the patient, for example, develop post-ligation syndrome, then we go ahead and start inotropics. Transportation, the key is to minimize the time of transportation in the cath lab and also minimize the procedure time as much as possible. NICU is the home of the baby, home of the premature infant. Moving the baby outside of NICU, it's basically put a lot of stress on the patient. We should pay attention to the body temperature. Premature infant, as you know, they have large body surface area. They can lose temperature very easily. So during transportation, we need to isolate with warming features. And if needed, we use plastic wraps and chemical warmers. We monitor vital signs. We need respiratory therapists to help with transportation. Also, we need bedside nurse, anesthesiologist, and NICU provider. Auto blenders also should be available because we don't want to give oxygen, large amount of oxygen. As you know, large amount of oxygen can increase the flow across the PDA and can flood the lungs. During the procedure or with transferring, we keep the patient the same ventilator. If the patient on high jet ventilator, we'll keep the patient the high jet ventilator. Switching to conventional ventilator is not needed for the procedure. As you know, the surgeons, a lot of time, they ask to switch to conventional ventilator because it's very difficult to cut through the chest and to ligate the PDA when the chest is shaking. This study, the first study we published in PDA closure using high-frequency jet ventilator. I think it's published in 2022. At that time, we closed 38 PDA by catheter. And we showed that high-frequency jet ventilator did not affect the success of the procedure. Procedure was successful in all patients with no cath-related complications. Transporting from other institution is not an easy task. It's very difficult. You need special equipment. You need people with experience. You can imagine it's much easier for the provider or the interventional cardiologist to travel to the patient to perform the procedure at bedside rather than transferring unstable patient to the cath lab where the procedure can be done. Anyway, it can be done, but it's not easy. This is a paper published in 2019. So the group in Memphis, they share their experience transferring patients specifically for PDA closure. And those are really small patients, less than 1 kilogram. The procedure was success in all patients. With no significant complications. Now in the cath lab, we set up the room temperature to more than 75 for the same reason, because we don't want the patient to lose temperature. Yes, it's hot for us. It's probably not, I would say, comfortable environment, but it's needed for the baby. We monitor vital closely, especially body temperature. When we put the patient in the cath lab table, we cover the baby with a plastic bag. We use forced air warming, like Bear Hugger. We get baseline echo in the cath lab for many reasons. First, we need to confirm that the PDA is still significant. Second, it will be a baseline for us. We assess the gradient across the aorta, gradient across the pulmonary artery. So if we put the device and we see the gradient get worse, then probably the device is in not good position. We obtain only venous access, usually only 4 French sheet, the smallest sheet that we have. The flush, we try to minimize the amount of fluid. So we use only 3 cc syringe, and we fill the syringe with only 1 cc saline. We should be very careful with catheter and wire manipulations. The heart is very thin. It's very easy to perforate the heart. We make sure the device in good position before we release the device. Yes, we can retrieve the device by catheter, but it's difficult in sick baby. Here is an example, the classic way or traditional way of closing the PDA in premature infant. So the catheter course is from the IVC, right atrium, right ventricle, main pulmonary artery, and inside the PDA. So we take the picture inside the PDA. We get the measurement, the PDA size. The most important measurement for us is the pulmonic end, the smallest diameter. And then we exchange the catheter that we cross the PDA with the delivery catheter. It's 4 French, slightly stiffer catheter, but still same size. The inner diameter is larger to allow placing the device inside it. And here how we deploy the device. The device is between the 2 radio-obic dots or markers. We like to have an NG tube or temperature probe because usually the NG tube aligns very well with the ampulla of the PDA or the aortic end of the PDA. So we intentionally place the device just anterior to the ampulla with the aim to place the device entirely inside the PDA, nothing protruding inside the aorta or protruding in the main pulmonary artery. After we deploy the device, we get angiogram in the main pulmonary artery. This to assess basically the flow in the left pulmonary artery and make sure there is no obstruction. And because we don't have arterial access, we cannot assess the aorta with angiogram. So we rely on echo. On the echo, we assess the flow across the aorta. When we are happy with the position, we release the device from the delivery cable. Before releasing, we can retrieve the device inside the catheter, use different device if needed. Once we release the device, then we assess with echo, make sure the flow in the aorta is normal. You see the device here, no residual flow, and we assess the flow inside the LPA. So all looks good. Here, what I like to see when after PDA closure, this baby is 30 weeks, you can see with just few hours, the congestion has significantly improved. This is the same patient, 30 weeks, was not intubated at that time before the procedure, intubated actually for the procedure. The baby was struggling with poor perfusion and a lot of respiratory symptoms. After closure, as you see, like the lung cleared up. This is not the case all the time, especially in very premature infant. For example, his 26-weeker. In this patient, you can see, yes, the lung has improved, edema has improved, but you still have RDS picture. Now, the next step, after we master closure with using contrast is to move to close the PDA in the cath lab, but without contrast. The advantage, avoiding contrast exposure, which can cause volume overload, acute kidney injury, or transient hypothyroidism. We shorten the procedure time, so we don't need to take picture in the PDA to get the measurement. Then we choose the device, then we prep the device. So we choose the device from the beginning based on the echo measurement. We prep the device before we start the procedure, and that can shorten the procedure time. Initially, our procedure time was around 40-45 minutes, but after adopting closing with only echo guidance without contrast, it's very common now we can complete the procedure with only 10 minutes. We rely on the echo and fluoroscopy to guide us, but we don't use contrast. The disadvantage, we need really experienced sonographer and cardiologist, and it's a little bit difficult. I wouldn't say impossible, but it's difficult when you have a baby, especially on the high jet ventilator. The acoustic window sometimes is not the best, and the quality of the picture is not great. It still can be done, but we rely on fluoroscopy to guide the catheter manipulation, and on echo, basically we Doppler. If we cannot see the flow in the aorta or in the LPA very well, we Doppler it and make sure the Doppler is, the flow velocity, in other words, is within the normal range. Here is an example how we can do it with echo guidance. With echo, we get the measurement of the PDA, and the PDA is the red flow here. Then you see the red arrows is basically delineate the catheter course crossing from the tricuspid valve to the right ventricle toward the RVOT. And the red flow here is the PDA, and you can see the catheters inside the PDA. After that, we deploy the device inside the PDA with echo guidance. Now you can see the device, we push the device outside the catheter. When the device is still connected with the delivery system, we get an echocardiogram again to assess the flow, assess if there is any residual shunt, and also the flow in the LP and the aorta. When we are happy, we release the device, and again, we get more echo image to to make sure the device is in good position. Here is another achievement. We just started that recently at the University of Iowa. Nowadays, we can actually close the PDA with a microcatheter. And with the advantage of this method, we can use the same microcatheter to cross the PDA and to deliver the device. Before, we need to cross with different catheter, then exchange for different delivery system. Now we can do everything with single catheter, microcatheter, measuring around only 1 millimeter. And here delineates how we are crossing the PDA. So the catheter was in the RVOT, and we send the wire across the PDA, then we follow or we advance the catheter, microcatheter over the wire, we remove the wire, and here how we deploy the device. Again, the device is between the two dots. We use the NG tube as our marker or landmark. When we are happy with echo that the device is in good position, then we release the device. Now the third step, bedside closure. Difficulties with bedside procedure is first we need team agreement. It's big undertaking. We need NICU to agree to perform the procedure at bedside. We need support from basically from radiology to help us with fluoroscopy machine if we need to use it. We need a sonographer also to guide us with the procedure. Room size, if the room is small, then we cannot do it at bedside because we need echo machine and fluoroscopy machine in the room. And definitely we need resources to support the procedure. The advantage of bedside closure, we can keep the patient actually in his or her own environment. The patient is stable in NICU for many days. We don't need to disturb that stability. The other advantage is the primary team familiarity. Primary team is NICU, neonatologist. So moving the patient to the cath lab will have less resources. Probably we can get one neonatologist, but we cannot get 3 or 4 of them, or we cannot get the resident or all nurses. Here we have all the team in the same area. Avoid the hassle of transportation, makes our work more efficient, and availability of the cath lab. A lot of times our schedule is full, so adding an NICU PDA closure, that requires the team to stay late. Minimize the risk of hypothermia, and I think the big advantage is the ability to offer the procedure at programs where they don't have pediatric cath lab. Then we can travel to other programs and close the PDA at bedside. This is a recent article, I think was published 2 months ago from Germany. So the team, they were able to close 53 PDA at bedside with echo guidance only at 18 different NICU. They had great outcome, 1 device embolization, the device was retrieved and the PDA was closed. They had 1 patient with pericardial effusion, they drained the effusion, and after a few days they closed the PDA. Otherwise, there was no significant complications. The disadvantage of PDA closure at bedside, it's a new environment to cath lab team. We are used to work in the cath lab. Now for us, we have to move to the NICU and to work in the cath lab. But I think preparing in advance, for example, if we get a cart that we need, all needed equipment are in that cart, we ask what we need, we meet with NICU, and I think it's very doable. Need for large space, because we need echo and fluoroscopy machine. Even if we do it with echo guidance, sometimes the quality of the image is not sufficient, and we still need to use the fluoroscopy machine. I don't think we need to get contrast or any angiogram. Fluoroscopy and echo guidance is more than enough. Here, general advices when we consider PDA closure at bedside. For interventional cardiology new to PDA closure, I strongly recommend starting doing the procedure in the cath lab with contrast use, because there's a lot to learn in terms of the procedure technique, in terms of the anatomy, and what's special about a premature infant. After mastering that phase, yes, probably when the interventional cardiologist is comfortable with doing the procedure in the cath lab without contrast, then we can move to bedside. In the programs who don't have pediatric cath lab, there are 2 options: either transfer the patient to other institution, or ask an interventional cardiologist with experience in performing the procedure without contrast to help with the procedure. But I will recommend starting the interventionist to start learning the procedure at bedside. Make small, achievable steps and learn from mistakes. Make sure we have fluoroscopy machine. Here is just a summary of the milestones. So first in the cath lab, we do the procedure with contrast use, then in the cath lab without contrast, and then finally at bedside. Here's my last slide, basically delineate how the setup of the machine. with the fluoroscopy machine, usually the fluoroscopy machine used for hand angiogram or hand picture. It's a really small machine. What you can see here is the incubator. The cover of the incubator was elevated, and the machine was placed on the side. You can see also the echo machine with the sonographer helping with the procedure. And to the right of the screen, actually, you can see the screen of the fluoroscopy machine and the interventionalist here is performing the procedure. Thank you for listening. And if anybody has a question, please contact me.
Thank you so much. We're going to have the questions at the end of the session. Thank you. It's a privilege to introduce the next speaker, Dr. Bilal Khawam. He's a pediatric cardiologist at Tawam Hospital. He's been with us for the last 3 years. He's very active in diagnostic pediatric cardiology. Also, he's very active in teaching our fellows how to do point-of-care ultrasound, echocardiogram as a bedside evaluation tool. Dr. Bilal will talk to us about approaching cyanosis and congenital cyanotic heart disease of a newborn. Please join me. Welcome, Dr. Bilal.
Thank you, Dr. Rahmani, for introducing me. First of all, I would like to get the opportunity to thank the organizing committee for giving me the chance to speak in front of you. I have nothing to disclose. So our learning objectives this afternoon is to understand the universal screening test of critical congenital heart defects, to understand the pathophysiology of cyanosis, to discuss initial management of cyanosis, and approach different case scenarios in cyanotic babies. Let's start with this scenario of one-day-old baby, term baby with normal vital signs, feeding well, not in distress, and the baby is ready for discharge. The nurse measured the saturation in the right hand, it was 96%, and in the right foot, it was 91%. On physical examination, the baby is totally fine. So what would you do? Would you discharge this baby? Who would discharge the baby? Please raise hand. So nobody would discharge. This is good, perfect. So the physician decided to discharge the baby, and the baby, he was vitally stable, and based on the vital signs, normal examination, so he was discharged home. And 24 hours after the baby was discharged, he was brought back again to the ER in shortness of breath, dusky, and hypotension with poor perfusion. This scenario has led the experts to put the algorithm for screening every baby before discharging home for critical cyanotic congenital heart defects. So what we do usually is to measure the saturation in right hand and one of the feet. The first measurement should be done at least 24 hours after birth or before discharge. And we consider it as pass test for the baby if the saturation is 95% or above, or there is no difference between the upper and lower of more than 3. And on the other hand, if the saturation is 89% in any of the extremities, we consider it as failed test. And we consider it as need to be retested again after 1 hour if the saturation is between 90 and 94%, or if there is a difference between the upper and lower body of 4% or more. So we do a second measurement. In the second measurement, again, the pass criteria for this test is 95% or above, or less than 3% between the upper and lower. And here the fail criteria is different a little bit in that the saturation point of 94% or below is considered fail as compared with the first test of 89%. And also if there's a difference of 4 or more between the upper and lower body, also we consider it as failed test. This is the most recent algorithm, and it's modified from the previous one, which was in 2011, in which they would decide to retest again if the saturation is again between 90 and 94%. So they would do another third measurement after 1 hour with the same decisions. This is not anymore taken. Just 2 measurements are enough to decide to further assess the baby. So if the test is positive, we should further assess. Now, when you are doing the test, as I mentioned, there may be a difference between the upper and lower body. So if the upper body is red and the lower one is blue, we call this phenomena as differential cyanosis. This is common in coarctation of the aorta and PPHN. And on the other hand, if the difference, the opposite happens, like the upper body is blue and the lower body is pink, we call this phenomena as reverse differential cyanosis, and we suspect the presence of DTGA with associated coarctation of the aorta or elevated pulmonary pressure. So the universal screening test of congenital heart defects is very important because it picks up 5 out of 6 babies with cyanotic defects. The cutoff saturation of 95% has a sensitivity of around 84% and a specificity of more than around 99%. This sensitivity is also greatest when we combine the pulse oximeter with the clinical assessment. It will increase up to 93% as compared with the pulse oximeter alone of 84% or clinical assessment alone with 77%. And this screening also shown to reduce the early infant death from critical congenital heart defect by 33%. So this is very important with the low-cost test and great outcome. However, still this test would miss some of the critical heart defects, so it has some false negativity, as we can see in pink tetralogy of Fallot or coarctation or severe aortic stenosis. Also, this test has some false positive, like we see in PPHN, pulmonary lung issues, and sepsis. Another method of screening of critical heart defects is fetal echo, which is usually done in the 2nd trimester of life of the pregnancy. So we usually assess the 4th chamber of the heart and the ventricular outflow tracts. And this screening would pick up some of the cyanotic congenital heart defects. So its sensitivity is highly variable depending on who's doing the test. So it is operator dependent and also depend on the gestational age, fetal position, and the type of the defect. However, it is extremely helpful when you detect a critical defect before delivery so you can plan the delivery in a proper center. Let's talk a little bit about some basic of the cyanosis. So cyanosis, by definition, as you all know, is bluish discoloration of the tissues, and it occurs when the deoxygenated hemoglobin exceed around 3 to 5 gram per deciliter of the total hemoglobin. So it is common in newborn and can be associated with life-threatening diseases. Cyanosis could be peripheral or central cyanosis. For peripheral cyanosis, it affects the periphery, hand and feet, and around the mouth, and it spares the mucous membranes. It is associated with increased deoxygenated hemoglobin on the venous side, and it spares the arterial side of the bloodstream. And usually associated with cool extremities, and it is difficult to detect cyanosis in dark skin. For differential diagnosis of peripheral cyanosis, as you all know, it is acrocyanosis is one of the commonest. We observe it in the newborn in the first 48 hours, which is benign phenomena. Also cold exposure may cause peripheral cyanosis. However, it could be a sign of sepsis or shock. Another differential is also venous obstruction, like we see in thrombosis. And polycythemia itself also can cause peripheral cyanosis. Central cyanosis usually affect the mucous membranes, including the lips and tongue, in addition to the peripheral organs. It is associated with increased level of deoxygenated hemoglobin in the arterial circulation. And as you all know, as a neonatologist, normally we observe the cyanosis in the first 10 minutes of life until the baby picks up with a saturation of 85 to 95%. On your left hand, two pictures of the peripheral cyanosis in the feet and around the mouth, and on the right hand is a baby with central cyanosis in the lip and tongue. This slide is important because it tells us when the cyanosis is clinically detected. So, as I mentioned, you need 3 grams per deciliter of desaturated hemoglobin to detect cyanosis clinically. So let's take an example of a baby whose hemoglobin of 8. If you divide 3 by 8, this is around 40%. So you need the saturation in this baby to go down to 60% to observe cyanosis clinically, as compared to the baby with polycythemia with a hemoglobin of 24. If you divide 3 by 24, is around 12%. And in this baby, you need to observe cyanosis clinically, so saturation should go below 88%. So it's easier to detect cyanosis in higher hemoglobin as compared with anemic babies. The famous oxygen dissociation curve. What we need from this curve is that everybody knows that fetal hemoglobin is the predominant in the newborn period. It's around 60 to 80%, and as compared with a 6-month-old baby who has only 5% of this fetal hemoglobin. So by default, for newborn, this oxygen dissociation curve is shifted to the left because of the more affinity to oxygen. So if we give him hemoglobin for same babies, newborn and 6-month-old, so same number of hemoglobin and with partial pressure of oxygen of 30, the newborn will have a saturation of 72 as compared with the 6-month-old baby who will have a saturation of 55. Now, what is the pathophysiology of cyanosis? We have 5 mechanisms of cyanosis, all of which will decrease the oxygen extraction at the alveolar level, ending with hypoxia. The first mechanism is alveolar hypoventilation, result from CNS problems, airway obstructions, or metabolic issues causing apnea. Another mechanism is VQ mismatch, which is the most common mechanism, like we observe in pneumonia, pneumothorax, and RDS babies. Third mechanism is diffusion impairment, like we see in pulmonary edema, which will affect the diffusion of oxygen from the alveolar side to the arteriolar side in the lungs. Fourth mechanism is right to left shunting, which will bypass the alveolar oxygenation like we see in intra or extracardiac shunting. And the last mechanism is the impaired oxygen saturation. Example is hemoglobinopathies like methemoglobinemia. This is a full list of the causes of central cyanosis with associated pathophysiology. Now, what should I do when I encounter a baby who is blue? First of all, we have to confirm the saturation, if is it normal or going down by pulse oximeter. And again, we measure pre- and post-ductal locations. And if the saturation is 95% or below, or if there is a 4% difference between the upper or lower, we consider it as significant desaturation. So we should be immediately alert and stabilize our babies. So if the baby is in respiratory compromise, tachypneic recessions, flaring, we should provide adequate airway, oxygen, and mechanical ventilation. And if baby is hypotensive or in shock, we need to grant the proper vascular access, both venous and arterial, for fluid resuscitation and blood pressure monitoring and maybe inotropic support. Also, we need to correct our acid base and metabolic status like acidosis, hypoglycemia, and hypocalcemia. Also, we may consider sepsis, so we need to start antibiotics. After all what we did to stabilize our baby, the baby is still not responding. At this point, we should be alert and we should consider the critical congenital heart defects. So we should start vitamin E, which is the prostaglandin E1. and get a cardiology consult. So we start the prostaglandin E1 in a dose of 50 nanogram per kg per minute initially, until we get the size of the BDA. So if the BDA is large, we may decrease the dose to 10 nanogram per kg per minute, or if it is small, we need to increase the dose up to 100 to reopen the duct. So this prostaglandin is life-saving, and its mechanism of action is vasodilation of the smooth muscles of PDA. It has some side effects on higher doses like apnea, hypotension, and neck. And if we need to transport the baby, we need to keep the prostaglandin running with the standard dose of around 50 nanogram per kg per minute. And some of the centers will electively intubate the baby to avoid the risk of apnea during the transportation. Again, in some rare instances, if you start the prostaglandin E1, still the baby is not responding. So we should be suspecting some rare cases of critical heart defects like pulmonary venous obstruction, like obstructive type of infracardiac total anomalous pulmonary venous return. This case would need urgent surgical intervention. Another example is the critical congenital heart defect with restrictive atrial septum, like we see in hypoplastic left heart and DTGA. These patients will need urgent catheter intervention and atrial septostomy. And what we usually do is that we go through the umbilical vein toward the IVC, toward the RA, interatrial septum, LA, and we inflate the balloon inside the LA, and we pull fast and we pull hard to tear the interatrial septum, after which the saturation will improve and the circulation will improve. Let's have some word about critical congenital heart defects. So by definition, critical congenital heart defects is any cardiac lesions that would need surgery or catheter-based intervention in the first year of life. This would include duct-dependent lesions, cyanotic lesions, and even large to left to right shunt like PDA, VSD, or AV canal. The incidence of congenital heart defects in general is 10 per 1,000 live birth, and out of this 10 is around 25% is considered as critical. So we have 5 categories of critical congenital heart defects. The first category is the left obstructive lesion category of the systemic blood flow, in which the baby is duct dependent and will get into shock and left ventricular pressure overload with heart failure symptoms and pulmonary edema. The second category is the right obstructive lesions of pulmonary blood flow. Also, this one is duct dependent, and when the ducts close, they present with severe cyanosis. Third category is parallel circulation, like TGA, and the fourth one is non-duct dependent cyanotic lesions, like we observe in truncus, total veins, and single ventricle physiology. The fifth category, which is non-cyanotic cardiac lesions, including VSD, BDA, and AV canal. Let's go through a few case scenarios. We'll start with this one of 3 days old baby, full-term baby, feeding and breathing difficulties, dusky. On physical examination, the saturation is around 90%, respiratory distress, tachypneic, retractions, tachycardia with gallop rhythm, hepatosplenomegaly, poor capillary refill, and poor pulses. So the baby is in heart failure. On ECG, right ventricular hypertrophy and right axis deviation, and chest X-ray showing large heart and increased pulmonary vascularity. And when doing the hyperoxia test, PO2, partial pressure of oxygen, was 120 after giving oxygen with FiO2 of 100% for 10 minutes. Chest X-ray showing congested lungs. And when doing the echo, one of the left obstructive lesions was diagnosed, like severe coarctation of the aorta, on interrupted aortic arch, or hypoplastic left heart syndrome. So the presentation of these left obstructive lesions is rapidly onset with respiratory distress, reduced systemic output. So the baby will be sick with poor pulses and metabolic acidosis. And usually these cases are easily confused for rule-out sepsis. So we need to early diagnose these babies and rapidly intervene. by starting prostaglandin E1, and we need inotropic support, sometimes like dopamine, epinephrine, only initially, because these drugs are harmful for the muscle cells. So until the baby is stabilized, we should wean these medications. And also, we may start Milrinone to reduce the afterload and improve our systemic circulation. And in these babies, we should avoid oxygenation and hyperventilation. This is very important. Oxygen is not always the solution. So in left obstructive lesions, if you give oxygen and you do hyperventilation, the baby will get more in trouble because more circulation will go to the lung and less to the systemic circulation. So we should avoid oxygen and hyperventilation. Also, if we increase the PEEP, the pulmonary vascular resistance will increase and will improve the systemic circulation by right to left shunting. In addition, we have to optimize our hematocrit for better oxygen delivery, and respiratory support will eliminate the work of breathing, and lung recruitment will be optimal for gas exchange. Case number 2 is about 1-day-old term baby, initially feeding well. Baby was healthy, and suddenly, acutely, he becomes cyanotic. On physical examination, baby is severely cyanotic, saturation of 60 to 70%, tachypnea, respiratory distress, plus minus murmur, ECG, left axis deviation with right atrial enlargement and left ventricular hypertrophy. Chest X-ray showing decreased pulmonary vascularity, and hyperoxia test showing a partial pressure of oxygen of 30 after giving FiO2 of 100% for 10 minutes. And this is the X-ray of this baby with decreased vascularity and upturned apex of the heart. And when doing the echo, one of these right obstructive lesions were detected, like tetralogy of Fallot, pulmonary atresia, intact ventricular septum or critical pulmonary stenosis. Another chest X-ray for another patient with similar scenario with big heart, huge right atrium, like we see in Epstein anomaly. And another example is tricuspid atresia. All are right obstructive lesions. So right obstructive lesions usually would present with severe cyanosis due to inappropriate pulmonary circulation. Saturation of the oxygen will be around 60 to 70. And this will lead to tissue hypoxia and cardiorespiratory compromise, and if not treated, leading to death. So we should restore our pulmonary circulation by starting prostaglandin E1. And we should, here, on the opposite to the previous scenario, we should minimize our pulmonary vascular resistance. So we should give oxygen. Also, alkalization would help, and keeping the CO2 on the lower side. Also, all of which will do pulmonary vascular dilation, and more blood will go to the lungs. Sedation also would help with fluid resuscitation. These babies would tolerate fluids resuscitation. Lung recruitment, again, for gas exchange, and optimize hematocrit to deliver good oxygen to the peripheral tissues. Our third case is about 1-day-old baby, term baby, noted to be cyanotic. On physical examination, he's tachypnic with symmetrical pulses, single S2, no murmur. So the baby is basically happily tachypnic. ECG showing right ventricular hypertrophy, and chest X-ray is normal with increased pulmonary vascularity. And when doing the hyperoxia test, again, partial pressure of oxygen is 42, and FiO2, after giving FiO2 of 100% for 10 minutes. And when doing the X-ray, we found this famous X-ray of the egg on string with increased vascularity and narrow mediastinum. And when doing the echo, it was showing this TGA. So for TGA, as you all know, the two systems are not talking together. The respiratory, the two circulation, the pulmonary and systemic circulation, as compared with the normal circulation in which they are connected on series. So if there is no proper connection between the two systems, the baby would die. And the best connection between the two systems is at the arterial level, and also ventricular or great artery level also may help. So the initial presentation, again, for TGA is moderate to severe cyanosis, and initially they will be happy tachypneic due to the excessive pulmonary blood flow. And if the baby is not treated, pulmonary hypertension would develop from pulmonary overflow, and they will become more severely cyanotic and may go into shock. So we should support the mixing for this baby. Prostaglandin E1 may help, but the best mixing would be at the level of the arterial septum. So if we have a restrictive PFO, we should do balloon atrial septostomy for these babies. Also, we need, again, to optimize our systemic output by optimizing hematocrit. We may need inotropic support. Also, we need to minimize our pulmonary edema by avoiding excessive oxygenation and hyperventilation. Diuresis also is a good idea. Lung recruitment for gas exchange, and for these babies, surgery is the treatment of choice in the first week of life. Our last case of a 6 weeks now, 6 weeks old baby, term infant, feeding difficulties, failure to thrive, shortness of breath, and sweating. On physical examination, saturation is 92%. Baby is tachypneic with retraction, wheezing, murmur, hepatosplenomegaly, and normal pulses. ECG, biventricular hypertrophy, and chest X-ray showing cardiomegaly, hyperinflation, increased pulmonary vascularity. When doing the X-ray, again, congested lungs, and when doing the echo, we found truncus arteriosus with any of these types. Another X-ray for a baby with similar scenario, showing this famous snowman X-ray, and when doing the echo, total vein was found. So for these volume overload lesions, we have subtle cyanosis with pulmonary overflow symptoms. So cyanosis is not easily to be detected clinically. That's why they may come later in life after 4 to 6 weeks with these symptoms. Associated, as I said, the increased pulmonary flow and waste ineffective systemic blood flow. And the treatment of choice in these babies is surgical or catheter intervention. Of course, until we do the surgery, we need proper medical treatment. So we should avoid oxygenation and avoid hyperventilation. And we may start heart failure medication. Initially, we may need Milrinone, in addition to furosemide, spironolactone, and eventually ACE inhibitors until we reach to the surgical time. In conclusion, so universal screening is very important. It detects 5 out of 6 critical heart defects. Fetal echo help in better planning for congenital heart defects. The screening shown to reduce early infant death from critical defects by 33%. Sensitivity of the test would increase if combined with the clinical examination. Cyanosis can be detected clinically when the hemoglobin is deoxygenated hemoglobin 3 or more. It is important to rapidly initiate proper management in cyanotic babies. Prostaglandin E1, as you all know, is life-saving. And we need to understand that oxygen is not always the answer. Sometimes we should avoid oxygen. And proper hematocrit would support better oxygen delivery, and mechanical ventilation at functional residual capacity is optimal for gas exchange. These are my references, and thank you for listening.
Thank you so much. Thank you, Dr. Bilal. We're going to have time for questions. I know there's a lot of questions going to be. So we left the last lecture for today is the most controversial topic. And this is by design, actually, because nobody have energy to argue that much. But it's really very controversial topics. And this is about to treat the PDA or not to treat the PDA. And I would like to welcome back Dr. Bassi.
Thank you very much. Yes, definitely I agree with you. I don't have conflict of interest, though I will tell you that this is the million-dollar question, and I don't have answer to it. And probably I'll leave you with more questions than answers. With raising hands, like how many of you does favor PDA closure most of the time? Most of the time, to say more than 80% of time. Like, I mean, with closure, medical, surgical, transcatheter. And how many of you does favor basically closure or rarely refer for closure? Let's say less than 5%. Okay. And how many favors closure when it's hemodynamically significant? All right. People who answer was only when hemodynamically significant is definitely the right answer. But do you think that we have a clear definition what hemodynamic in PDA? Exactly, yes. Yes, this is the real problem, I think. Correct. So we know the PDA closes most of the time in a full term at the 3 days of life. And ductal closure is delayed in premature infants, and it's inversely proportional to the gestational age. At 7 days of life, if the baby is more than 30-week gestation, most of the time the PDA will close. If the gestational age less than 28 weeks, then most of the time the PDA will continue to be open. Now, the PDA is, as you know, is a tube connecting the aorta with the pulmonary artery. Because the pressure in the aorta is higher than the pressure in the pulmonary arteries. In other words, the pulmonary vascular resistance in the pulmonary arteries is lower than the aorta. The blood prefers to go to the pulmonary circulation when the PDA is large. And as a result, that can cause pulmonary overcirculation and systemic hypoperfusion. Pulmonary overcirculation symptoms and signs like pulmonary edema, pulmonary hemorrhage, pulmonary hypertension, bronchoventilation, development of bronchopulmonary dysplasia, and interestingly, like kids with PDA, they have 4.5 times higher risk of developing bronchopulmonary dysplasia. And the risk of bronchopulmonary dysplasia is not related only to the size of the PDA, but also the duration of ductal dependency. Systemic hypoperfusion, like stealing the blood from systemic circulation, can cause IVH, acute kidney injury, necrotizing enterocolitis, hypotension, especially diastolic hypotension, and there is increased risk. There is increased association with death, like the death is 4 to 7 times higher in kids who have PDA. If we use our logic, we know that PDA is associated with bad outcomes. Then closure should improve the outcomes. Surprisingly, randomized controlled trials, meta-analysis, systematic reviews failed to show benefit from PDA closure, like targeted closure. I'm not talking about conservative, target closure with medical, surgical, or transcatheter. Then we should ask ourselves 2 main questions. Does the treatment, medical or surgical, cause more harm than help? The second question, are we targeting the right population? So some literature review, what we have more than 25 systematic review studies and more than 70 randomized controlled trials and thousands of retrospective studies, and yet we don't know if the PDA, and we still debate who should we refer for closure. What does not exist in the literature, we don't have agreeable definition of hemodynamically significant PDA. Everybody says, yes, we close hemodynamically significant PDA, but there is wide variation how we define hemodynamically significant PDA. So if we cannot define what the PDA, then how we can study it? We are chasing a ghost. Second problem, there is no single randomized controlled trial with absolutely no treatment. All trials, they allow for rescue therapy. The problem with rescue therapy, yes, is not ethical not to treat a patient when we think the PDA is hemodynamically significant, but not treating patients can, or allowing for rescue therapy can basically contaminate the results and will be very hard to draw a conclusion. The third missing part in the literature, we don't have single randomized clinical trial on the use of newly available devices versus other treatment options such as surgery or medical treatment. Challenges in PDA management. First, it's very hard to distinguish or separate the PDA signs and symptoms from those caused by RDS or bronchial dysplasia. What significant PDA is, we don't know the answer for that yet. What does the PDA size and shunt, it vary in the same patient in response to many factors. And do we need really to close the PDA knowing that delayed spontaneous closure can happen without medical treatment? Timing of closure. Should we close in the first week of life or first 10 days of life knowing medical management is more effective during that time period? or we should do early closure, less than 3 days of life, knowing that PDA is not helping, then why to wait for a few more days? And what approach to choose, medical versus intervention? If we say medical, what's the first line? And we choose intervention, is surgery versus cath. We don't have clear recommendations when to close the PDA in premature infant. However, in older children, we have clear recommendation from American Heart Association. So it's indicated when it's hemodynamically significant, and they define significant PDA when you have left heart dilation or with or without symptoms. And even they consider it reasonable to close the PDA in hemodynamically insignificant to reduce the risk of endarterectomy. And I need to tell you, probably few or some cardiologists, they would recommend PDA closure in a premature infant if they see dilation in the heart. I think this is strongly wrong for many reasons. First, PDA closure in children more than 6 kilograms is extremely safe, but it's probably not safe in small children, in small infants, less than 6 kilograms. And PDA has no chance to close by its own in older children. And the most important part, again, premature infants are not small children. They are definitely different group. They have their own morbidities and mortality. Clinical findings suggesting significant PDA. What in the literature, I cannot mention everything, but most common findings, need for substantial support. So if the main airway pressure more than 8, or if IO2 need more than 40%, probably the PDA is significant. But again, if the patient has RDS, will need probably high pressure and will need high IO2. Second, pulmonary hemorrhage. Yes, PDA can cause or associated with pulmonary hemorrhage, but again, if the patient's volume overloaded, that can cause also pulmonary hemorrhage. Widened blood pressure. It's really good indicator for significant PDA, like significant stealing from systemic circulation. But if the patient is infected, we can see also widened blood pressure. Cardiomegaly and pulmonary edema and chest X-ray. RDS is very hard, I think, in my mind, to differentiate RDS picture from pulmonary edema. Hypotension requiring vasoactive infusion. Again, many factors can affect. Maybe if the patient is infected, we need to start vasoactive infusions. And signs of hypoperfusion, such as oliguria, AKI, metabolic acidosis, NEC, and again, many factors, many other problems can cause those. So it's very difficult based on the clinical picture to say, yes, this PDA is significant just based on the clinical picture. Echo findings, also some echo findings suggesting significant PDA. The most common findings in randomized clinical trials is the absolute number of the PDA. So most of the randomized clinical trials, they choose 1.5 millimeter. I don't agree with this because simply if the patient is like, let us say 2 kilograms versus 600 kilograms, we cannot say 1.5 is the same. In addition, I think indexing to the body surface area or the LPA, just index it to something will be more accurate than the absolute number. I'll have a couple of slides indicating that the diameter is not enough to assess the PDA. Unrestricted flow across the PDA, low velocity. So if the PDA is large, then a lot of shunt will be, a lot of blood will be redirected from the aorta to the pulmonary artery. That will raise the pulmonary artery pressure, and then the difference in the pressure by echo across the PDA will be low. But also if the patient has high pulmonary vascular resistance, even if the PDA is small, you will have low velocity. Diastolic reversal flow in the abdominal aorta, I think it's good marker and should be included to any scoring system. Superior mesenteric artery flow pattern, LA, LV enlargement, LA hypertension, pulmonary venous flow pattern as well. Let us go back again. Is the PDA side alone is sufficient to identify significant PDA? So what affects the flow, I think what the pathophysiology is related not to the size of the PDA, is the amount of the shunt. What affects the amount of the shunt for any cardiac lesions, 3 main factors. First, size of the PDA. Yes, the larger the defect, the greater the flow or the greater the shunt. But the length of the PDA is an important factor, which is very hard to study by echo because the echo tend to underestimate the length. The longer the length, meaning more resistance to the flow and the lesser flow. And the more important factor is the difference flow in the resistance. So systemic versus pulmonary vascular resistance. The bigger the difference, the bigger the flow. Just to reflect to something we always deal with, VSD for example. If the patient has a VSD, most of the time as cardiologists, we don't recommend medical management until we start seeing signs and symptoms of pulmonary overcirculation. The reason for that, because naturally pulmonary vascular resistance is high in the first few days or weeks of life. I would say the same logic actually. Pulmonary vascular in premature infant is high in the first, especially the first few days of life. And this is my argument against early closure. And actually, a lot of premature infants, they will continue to have high pulmonary vascular resistance the entire their life or for long term of life. So the normal physiologic dropping in the PVR sometimes get delayed or a lot of times get delayed in premature infants. Again, is the PDA size measurement by echo is accurate? I don't think it's that accurate because we did a study. We presented that in Beck's meeting, and hopefully this study will publish soon. So the first 60 PDA we closed in the cath lab when we were doing contrast angiogram, we assessed the PDA size in the cath lab by echo and also by angiogram. So we found there is moderate correlation, and you see the coefficient factor is 0.6. And the echo tends to overestimate the PDA size. And there is average bias of 0.4 millimeter at the narrowest PDA diameter. This is a very nice study also where they create a scoring system about the significant PDA, and they try to see if the PDA size in isolation can be used as a surrogate for hemodynamic significant PDA. And again, they found the size alone is actually poor surrogate for hemodynamic significance. So all what we have now, like most of the trials, clinical trials, actually they rely on the size of the PDA, where we say the size of the PDA is not enough. What are the PDA treatment options? Either conservative, medical, indomethacin, ibuprofen, or acetaminophen, surgical ligation, and recently transcatheter closure. Let us start with medical treatment. There are many studies, again, try to compare the effectiveness among different medications. This is a systematic review. They included 68 randomized clinical trials, and more than 480 patients were studied basically. And they found the high dose of oral ibuprofen has higher likelihood for PDA closure compared with the standard dose of basically IV or oral ibuprofen or IV indocin. But again, placebo or no treatment is not inferior to the result or the outcome placebo or basically no treatment is not inferior to patients with PDA. And in fact, some studies that showed treatment, the group that received treatment, they have worse outcome. Again, let us use our logic. Why does not medical treatment improve outcome despite it has a proven effect in closing the PDA? We know medical treatment helps closing the PDA, but there is no improving the outcome. Possible answers, either side effect of treatment cancel out the positive effect of closure, or we again targeting the wrong group, or other possibilities that we don't know, or I couldn't come up with something. I like this study, TIP study, and I think most of you are familiar with this study. It's basically prophylactic indomethacin. So we know indomethacin can prevent IVH, and also medical treatment is very effective in the first few days of life. Then they did a randomized study where they give indomethacin the first few weeks of life, first few hours of life, and they studied neurological outcome and the outcome in bronchopneumonia, dysplasia, and survival. So clearly you can see the incidence of PDA in the group that received indomethacin or the incidence of the PDA was roughly 50% less than the placebo group. So we know the indomethacin is early treatment or prophylactic is effective in closing the PDA. But what's interesting here, the last line, I want you to pay attention here, that the group that received indomethacin and they don't have PDA, actually they have higher risk of bronchopneumonia dysplasia, 43% versus 30%. So in other words, if we close the PDA, actually, even if we close the PDA, we cause more bronchopneumonia dysplasia. Again, we become to the same question. Why is that? And the nice thing about this study, which I like specifically about this study, they follow the patient in the need of FiO2, like oxygen, for 7 days. Unfortunately, they did not study other parameters, but only the oxygenation. And they found once you start treatment, those patients, they require more oxygen administration. And there are few studies, and their argument, indomethacin probably increase the inflammation, increase the edema in the lungs, and again, that will require more respiratory support and probably will cause more harm than benefits in patient who doesn't need PDA closure. The advantage, what we learned from TIP study, we know prophylactic treatment does not improve the outcome. PDA elimination also is not universal. It reduces the PDA incidence by 50%, but will not be able to close all PDAs. And the group with PDA treatment has higher incidence of bronchovenous dysplasia compared with our treatment. Again, the question, does Indocin cause more bronchovenous dysplasia? The drawback of this study, unnecessarily we treated patients in whom the PDA would completely close by its own, and also in the group in whom PDA was hemodynamically insignificant. I think what we learned also from this study that we should identify the group with high risk to target them with treatment. There is another trial, Tolerate trial. The logic for this trial, most PDAs, they close by their own in the first week of life. Yes, there are delayed closure, but most of them in the first week of life get closed. So they waited for 1 week, they get an echocardiogram, and at that time, if the PDA is large, they offer medical treatment. They found early treatment did not reduce the PDA ligation risk, but what's interesting in this study that late onset of sepsis was higher in patients more than 26-week gestation. Let us dive more into this study because I found this is very, very interesting. The echo criteria, again, 1.5 millimeter, which is the most clinical trial they use that one. But what I like here, they use another criteria, another additional criterion to include the patient. For example, they use left atrium to aortic root ratio more than 1.6, meaning there is dilation in the left heart. The drawback of this one, the dilation of the heart needs some time for the pulmonary overcirculation, for the LA overflow to dilate the heart. But also when the PDA gets close or gets smaller in size, the dilation will take some time. So for sure, we included some patients in the study in whom the PDA was not significant. But it's better than just saying 1.5 millimeter. They did randomization, but unfortunately, despite randomization, the groups are not comparable. The group that received treatment, they have actually infection, higher risk of infection. They were actually infected at that time. 77% of them, they have early onset bacteremia. Here's the table of the findings. At 10 days of life, again, the group that got treatment, the PDA got reduced by 50%. But again, the risk of bronchovenous dysplasia did not improve, despite the PDA got closed. Bacteremia, I found this very interesting, but I cannot explain it. They found the group that they received Indocin, they got higher, or they had higher risk of bacteremia or late onset bacteremia, but it's only for kids who are more than 26 weeks. Kids younger than 26 weeks, they didn't have higher risk of bacteremia. So this is another factor. I don't think there is logical explanation. But it makes sense if you have late onset bacteremia, is basically to have more risk of death. So I think the risk of death is not related to the treatment, probably related to the bacteremia, but hard to prove it. What's the advantage of this study? So early treatment at 7 days increases the closure risk, improve the chance of closure twice, meaning, in other words, reduces the chances for the PDA to stay open by 50%. PDA elimination is not universal. The risk of bronchovenous dysplasia did not change with treatment. The group with no PDA after treatment has higher incidence of late onset bacteremia and death. It's hard to explain this one. The drawback of this study, again, randomization was not perfect. The groups were not comparable. And there's high percentage, I should go back probably here. I don't know how to go back here. Yes. There is high percentage of patients who need basically rescue therapy. So rescue therapy was higher in the group that did not receive medication. And if I read it accurately here, so 40% in the group less than 26 weeks, 40% of patients who received Indocin basically needed rescue therapy, but 80% actually, most of the patients less than 26 weeks, they receive rescue therapy. Then it's very hard to draw a conclusion if you end up treating the patient who your intention initially not to treat. Again, I think we should have better system to identify the group that would benefit from closure. There is another 2 trials, very famous trials, recently got published, Benedictus and Baby Oscar. In this study, they offer early treatment, and they target the patient less than 28-week gestation. Again, in Benedictus, their inclusion criteria is the PDA size 1.5 millimeter with left to right shunt. That's the only thing they want, which again, I don't think it's accurate to say 1.5 millimeter. Randomization, ibuprofen versus placebo, and there was no change in death and bronchial dysplasia. Baby Oscar, it's very similar, but they also included patients with when the right to left shunt less than 30%. As a cardiologist, I'll tell you, if there is right to left shunt, even 10% or 5%, pulmonary vascular resistance is high, and mean the amount of shunt is really small. So it's even if you measure the PD at 3 millimeter, the shunt is negligible. Despite that, they included those patients, and again, there is no change in outcomes in terms of death and bronchial dysplasia. In the paper of the Benny doctors, they actually acknowledge that the PDA diameter as an inclusion criteria is imperfect. So the drawback of the study, the process of selection is imprecise, and ibuprofen may cause harm because by canceling the positive effect of closure, because even patients who had the PDA got closed, that did not change the risk of bronchial dysplasia. All right, so this study, very nice study. So they included 139 NICU with high volume, treating patients with very low birth, premature infants. And what they wanted to study at that time, the rate of treatment, medical treatment or surgical with the final outcome. So they found in this study that the rate of treatment varies as expected from 13 to 77%. Interestingly, that the relationship between PDA treatment ratio and outcomes was U-shaped, meaning both low and high PDA treatment rates were associated with death or severe neurologic injury, whereas the moderate approach, between maybe 50% or 30% of the time of treatment, they have optimal outcome. So what we can conclude from this study, yes, there is a group that they will benefit from PDA because, over-treating will have worse outcome, but under-treating also have outcome. But again, how to identify this group, I think this is the main question here. Surgical ligation, it's really old. The first procedure was done in 1939. It has many advantages, can be done at bedside, is 100% success rate, but also has many disadvantages. Mortality rate is high. Hemodynamic instability, especially after the procedure, post-ligation syndrome is very high. It's probably around 20 to 30%. Blood transfusion, the need for blood transfusion, risk of infection, chylothorax, pneumothorax, vocal cord paralysis, scoliosis, and scar. This study compared the result of surgery with medical treatment, and you can see that the risk of death, regardless of the cause, was around 20% or 25% in the group that underwent surgical ligation. Post-ligation syndrome, also it's very common. In this study, they found that 31% of infants, they develop post-cardiac syndrome, post-ligation cardiac syndrome. And they found also that the kids who develop post-ligation cardiac syndrome, they have higher risk of developing severe bronchial dysplasia. All right. Here they compare all outcomes in terms of treatment, medical versus surgical. They found also, again, significantly higher mortality and morbidity with surgical patient who underwent surgical ligation. And there is no significant difference in the outcome in patients who treated with indomethacin or just conservative management. Here we should acknowledge that most patients who refer for surgical ligation, actually they are sicker patients, and probably that's why one of the reasons why the high risk mortality, but also there are mortality causes and other comorbidities associated with the procedure itself. PDA closure, again, first device available or approved by FDA was in 2019, Piccolo device. There are other devices available also. The advantage of those devices is they are soft, can be delivered through a small sheath. Is a picture of the PDA device. His multi-center study, our program coordinated that study, where we studied the different type of devices. Like we have the KA microplug device, we have the Piccolo device, and we have microvascular plug. So in total, we have 278 patients. Mortality rate happened in only, it's 0.4, so only one patient had hemopericardium, and BAS because of that. There is mild risk of increased LPA obstruction or aortic obstruction, tricuspid valve regurgitation, but most of those patients, the obstruction improve with timing, and also tricuspid valve regurgitation improve with time. Success rate was very high, and complication rate not that high. The procedure time, though, at that time, the average was around 35 to 40 minutes. This is our recent study describing our experience in closing the PDA using the KA microplug in kids weighing less than 1,500 grams. We had 18 patients because we are more familiar now with the procedure. That cut down our procedure time to 28.5 minutes. Success rate was 100%, no cath-related complications, and on follow-up, all patients were alive, with no residual shunt or abnormal echo findings. And again, this is when the time where we're using contrast. Nowadays, we close the PDA without contrast use, and our procedure time much shorter, and sometimes we can close it, or a lot of time we can close less than 10 minutes. Now, comparing PDA with surgical ligation. So it's clearly, in this study, they showed that patient, very low birth weight infant, who had PDA closure, they have better outcomes in terms of the need of oxygen and respiratory support. Post-ligation syndrome with PDA versus, with transcatheter closure versus surgical closure. So none of the patients in this study, 76 patients underwent transcatheter closure. None of them developed post-ligation cardiac syndrome versus 13% developed that syndrome. And hospital death, regardless of the cause, was like 3%. Surgery was 18%. Death related to the procedure was 0 in the cath group and was 5% in the surgery group. And this is specifically procedure-related death. Major complications, 21% in the surgical group and only 5% in transcatheter group. All right. This is meta-analysis and systematic review study. They included 12 study with 4,668 low birth weight infants, comparing transcatheter closure with surgical closure, and there was actually the findings is favoring transcatheter closure in terms of hemodynamic instability during and after procedure, and also in terms of death. Does transcatheter closure reduce the risk of bronchial dysplasia? I don't think we have the answer yet. This is a new procedure. This question needs to be answered. But I think most likely yes. The reason for that, I'm saying most likely yes, because transcatheter closure is associated with shorter mechanical ventilation than surgery, and is not associated with significantly with post-ligation syndrome. And we know that the length of exposure mechanical ventilation is the most important risk factor associated with bronchial dysplasia. So by shortening the ventilation time, by not having post-ligation syndrome, which are the two common risk factors for bronchial dysplasia, I think it's probably will be less than surgery, but I don't know about that compared with other medical treatment. Table comparing the two transcatheter versus surgical closure. Transcatheter is less invasive, minimally invasive. Time to work immediately. It's 100% effective. Side effect 3 to 5% versus 10 to 30% in the surgery. Post-ligation syndrome is very rare. Intubation time shorter. And procedure-related mortality is just few cases in the literature. Overall mortality 2% versus 17%. Again, the risk of bronchial dysplasia need to be studied. Take-home message. Hemodynamically significant PDA should be clearly defined. Closure is not risk-free. Risk and benefit should be weighed. Medical treatment does not improve outcome when the target group is imprecisely selected. I think the first thing we need to define and agree what hemodynamically significant PDA is. Transcatheter closure is safer than surgery. The timing of transcatheter closure and the effect on outcome are yet to be determined, and studies are needed to compare PDA devices with other medical treatments. Thank you.
Thank you so much. So ask Dr. Bilal to join us at the podium. Please, for a second for questions. So we open for questions now. Where is Dr. Maurice? Is Dr. Maurice around? No, he's left. Okay. Dr. Hamler? Please. First question.
My My name is Helmut Hummler. I am a German neonatologist working in an environment where we rarely actually ligated patients. When I moved to Sigra Medicine working with Ziad Hijazi, I realized there are different approaches in the world, and it was very difficult not to ligate or to close a PDA. The best method was to avoid the cardiologist to see the baby. So that's a provocative comment, sorry about that. But I have actually another question for you. If the prostaglandin synthase inhibitors, if there is this suspicion that they would affect the development of the pulmonary vasculature, and that might cause a detrimental effect in those babies who are exposed to these drugs. What's your take on this hypothesis? Is there something true on this? I mean, that would basically mean that we should expose them as little as possible and avoid repetitive courses of indomethacin, of ibuprofen, and even paracetamol.
Can I just interject here, just because Dr. Bilal's lectures, if you didn't get it, he said vitamin E. This is not the vitamin E for a neonatologist. He's talking about prostaglandin E2.
It's
So
just a
if you didn't
metaphor.
get it, that was a joke, but that's kind of like this explanation. Please.
Yeah, this is a great question. I think in the TIP study, like it showed like when you give indocin, those patients need more oxygen. And
Yes.
in the discussion also, they mentioned a couple of papers indicating the possibility that the indocin or ibuprofen can cause more lung injury. So I don't know if we have really strong evidence, but it's definitely concerning. And I think this is a logical explanation why when, despite we close the PDA or indocin or ibuprofen effective, in closing PDA, but the outcome does not improve.
I think the discussion in the TIP trial was more or less related to urine output. So giving them indomethacin, there's a lower urine output, therefore you might end up with more pulmonary edema, and that might affect gas exchange. But I think that the other story is probably more interesting.
Yeah. Thank you.
Thank you. Next question, please.
Hi, this is a question regarding the use of device closure versus medical treatment. What would be the timing? Like like we know that Brufen is safer than indomethacin, and paracetamol is safer but less efficacious, non-inferior to Brufen. In this era where paracetamol, Brufen options are there, and we are not talking of preterm babies like 28 weeks or 27 weeks. We are talking of babies 22, 23, 24 weeks where PD is a real problem. Babies stuck on ventilator for a long time, high frequency, and the chance of developing BPD is very high. So what is the possibility of closing these PDAs in babies like 600, 700 grams with a device closure? And when will it be done? What is the best time for those device closure to be done? After 1 week, 2 weeks, 3 weeks, 4 weeks, or after the BPD is established?
That's a great question. Honestly, each institution is different. First, we don't know if the transcatheter closure will have better outcome. This is a new procedure. I don't know if we should recommend like transcatheter closure, let's say in the first week of life. Maybe it's worth trying medical treatment. Every institution is different. Our institution, we try cetamol first, and then ibuprofen, 2 courses. If there is no response and the PD is still significant, then we refer for closure. In terms of is it doable, less than 700 grams? Yes, it's doable. We have close 600 grams. But as you imagine, probably the risk is slightly higher compared with bigger patients. Thanks.
Thank you. Next question.
Thank you. My question is again about the PDA closure. The medical closure, you mentioned about the ibuprofen and its effects actually probably causing adverse outcomes. Was something like that looked at paracetamol or acetaminophen?
Yes, cetamol is effective, but as mentioned earlier, is less effective than indocin and ibuprofen.
Yeah, but I was talking more about the adverse outcomes. You know, you talked about medical closure, then the adverse outcomes. So, but paracetamol, slightly different mechanism. So, were those patients also moving towards adverse outcomes, or not really studied yet?
I don't think I came across any study mentioning that cetamol can increase the risk of bronchial dysplasia. but you know, it's relatively still new medications.
Thank you.
Just one question, Dr. Bilal. Does nobody have any questions? You mentioned in your presentation the hyperoxia test. And as a neonatologist, we moved away from hyperoxia tests for the problems with hyperoxia and ROP. So are you still believe in hyperoxia test?
My comment on the hyperoxia test, it was back in the old days when they don't have the, access to the cardiology service soon. So they would do this test just to see if there is a critical congenital heart defect. I think the recent practice is going away from this test.
Yeah, we don't.
Especially we know that
We don't recommend it anymore. So.
oxygen is always harmful in the newborn and then extreme preterm babies. We all know this.
And maybe a question for Dr. Basil, that if we are as an institution, are we interested in starting program of transcatheter closure of PDA? Would we need to have a cardiothoracic surgery service as a backup in case we start the service?
Yeah, that's great questions. A great question. So yes, complications can happen, especially cardiac perforation. Unfortunately, it's very, very rare for the surgeon to intervene on a patient if you have complications. The reason for that, because the technology is not there. We don't have bypass machine that the surgeon can put the patient on a bypass machine and do the surgery. Most of the time, I would say sometimes, not most of the time, when you have pericardial effusion and the perforation is large, the surgeon can't do nothing. There are few cases where the surgeon were able to do something, but the bleeding was very slow. For example, there is a case report where the perforation in the appendage, and they were draining the blood over 2 or 3 hours, and they were racing the blood, but the bleeding was so slow. The cases reported in the literature, though there are just few cases, the bleeding was large, and the surgeon, there was no surgical option. We discussed that always. We discussed that with our surgeon, and he confirmed that.
Would you
surgery is not needed.
disclose this with the family before you get the consent as a possibility?
Exactly. Yes, as a possibility. I think as the same thing with surgery, like risk from or mortality from surgery, it's around 2%. Risk from cath, less than 1%. So it's still lower than surgery.
Thank you very much. If there's nobody have any questions, that will conclude the session for this afternoon. We hope that you enjoyed this session, and we hope to see you tomorrow. We're going to have a lot more lectures coming your way, and thank you very much for sticking out until the end. Thank you.